my talk on the clinical examination findings of Pes Cavus and how to manage it. Now, can everybody see my presentation? John, can you see it? Fine. Now, regarding Pes Cavus, initially it used to come in your FRCS Orth exam as a short case, but lately it has been coming regularly as an intermediate case. So if you are in a short case, then it is one of the difficult cases in FRCS Orth exam, because like brachial plexus injury, Pes Cavus examination within the constraints of those 5 minutes and discussion of management can be difficult in the exam scenario with the tensions involved. So we'll try to make it a bit more simpler so that it is easier for you to understand how to examine and how to manage Pes Cavus cases. Now, sorry. So I do not have any conflicts of interest, but I would like to acknowledge BOFAS, the AO Trauma, for some of the facilities that they offer, and the Newcastle unit for sharing some of the videos. Now, the ways a Pes Cavus patient will present to you is worsening deformity. They may have recurrent ankle sprains due to giving way of the ankle. Sometimes they come in with pain under the metatarsal heads, i.e. metatarsalgia. And generally, the commonest presentation would be general foot ache, especially if they've been on their feet all day. They are in agony by the end of the day. Now, to understand the mechanics of Pes Cavus, we need to understand how the foot is balanced. Now, if you imagine the foot like a chariot with at least 6 or 8 horses running that chariot, all the horses have to be equally strong in order for that chariot to go in a straight line. If the left-sided horses are more stronger than the right-sided horses, the chariot will go in circles anti-clockwise. And if the right-sided horses are stronger, then it will go in a clockwise fashion in a circle. Something similar happens in the foot. Now, the opposing muscles in the foot are in dorsiflexion, the strongest muscles are tiband and the extensors of the toes, and posteriorly, they are opposed by the calcaneus. So if we see it on the lateral view, what causes dorsiflexion of the foot, the strongest muscle being the tiband, and a bit contributed by EHL and EDL, which is then opposed by the plantar flexion forces generated by the gastrosoleus complex. Now, regarding the first ray, the strong plantar flexion force of the first ray is generated by the peroneus longus, whereas dorsiflexion of the first ray is mainly contributed by the EHL and partly by the tiband. Regarding the varus and valgus forces, the predominant inversion type of force is by tib post, small contribution by tiband, and the predominant everting force, that is the outward force for the ankle, is through the peroneus longus and brevis. Now, in cases of Pes Cavus, the main pathology is that the intrinsics are very weak. The intrinsics of the foot balance the metatarsophalangeal joint to keep it stable and plantigrade or in plantar flexion force. When you lose the intrinsics, similar to what happens in the hand, where you get a claw hand deformity, because of the stabilization of the intrinsics being lost, you get exaggerated forces of the EHL and FHL, which causes hyperextension at the metatarsophalangeal joints and flexion at the interphalangeal joints for all the toes. In Charcot-Marie-Tooth, which is the commonest cause of Pes Cavus in this country, the tibialis anterior is the weakest muscle, along with the peroneus brevis. They generally have a normal tibialis posterior and a normal peroneus longus, but because the rest of the muscles are more weaker, they become the stronger muscles. Now, this is a famous line that in a land of blind, the one-armed man is the king, which in Pes Cavus cases means that the stronger of the weak muscles is the one which drives the deformity. So in cases of Pes Cavus, we've got a weak tib band. So the dorsiflexion force of the foot is very weak. We've got a very strong peroneus longus, which then causes the plantar flexion of the first ray, which is classically called the drop first metatarsal. We've got a strong EHL, which causes the clawing of the big toe. On the lateral view, we've got a very strong, on the plantar view, we've got a very strong inversion force by the tibialis posterior, and we've got a very weak eversion type of force, which is by the peroneus brevis. Now, in features of the Pes Cavus, if you're doing clinical examination, what you would see is a high arch foot, a varus of the heel, clawing of the toes. You should examine their footwear as well as their insoles. You'll classically see that there is lateral wear of the shoes, and you will see callosities under the metatarsal heads as well as generally at the fifth metatarsal base. This demonstrates that they predominantly walk on the outer border of their foot. Now, when you see them walking, what you should see from the front is that they tend to have a heel varus. They get clawing of their toes. And if you can notice, they have a slight foot drop, which is better seen on the posterior views. On the left-hand side, you can see that she's dragging the foot, and you can see a varus thrust whenever she weights bears on the left heel. This is more seen on the lateral view as well. You can see on the left foot that she's recruiting the long toe extensors as there is weakness of dorsiflexion of the foot. So the long toe extensors are mainly used to clear the ground, but tend to drag it along the ground. Now, these findings may be subtle, but if you then examine, if you're in doubt, you should make them do some form of exercise, like go for a walk or a run and re-examine them. The muscular weakness will be much more apparent once their muscles have been a bit weakened. Now, in addition to those deformities, what happens is a rotational type of deformity in the foot, where the heel is in varus, as well as the forefoot is in pronation, i.e. the first metatarsal is significantly plantar flexed compared to the rest of the metatarsals. What does that do? The drop first metatarsal causes them to hit the ground with the first metatarsal when they are walking. And in order to get the forefoot flat on the ground, they have to invert the rest of the foot, including the heel, which causes the varus deformity of the heel, and the exaggerated arch. This is the basis of your Coleman's block test. So in Coleman's block test, you would find that in a patient with a heel varus and a high arch, you should always do a Coleman's block test. This is very, very much important, similar to what you would do like a Trendelenburg test for a hip case. If you see a high arch foot or a heel varus, please do make them do the Coleman's block test before you make them sit down. So as you can see, the heel is in varus. And when you put them onto a block and do the Coleman's block test, you'll find that the heel is corrected in patients who have a flexible hindfoot. So if you notice the 1A picture on your left, where the entire foot is resting on that board, you find both the heels are in varus. You ask them then to drop their first metatarsal head off that block on both sides, which will then allow them to full weight bear on both sides, and you'll notice a correction of the heel. Now, I like to do my Coleman's block test with them weight bearing on both feet with blocks of similar dimensions on both sides. But if it is not possible to do that, You can do it on one side, but they need to weight bear on that side only. Only the first metatarsal head should be off the block. And if there is correction achieved, that is the heel converts from valgus to varus, you have to talk about it in the form that the heel did correct from varus to valgus on Coleman's block test, and that suggests that part of the deformity is forefoot driven and the hind foot is flexible. So I repeat, the conclusions of a change in the Coleman's block test is that the deformity is at least partly or maybe fully forefoot driven, i.e. driven by the first metatarsal head being dropped, and that the hind foot is flexible. In patients who have stiffness or arthritis, they may not be correctable and you would get no correction on the Coleman's block test. Now, you do need to examine neurology in cases of Pes Cavus. The sensations would be as you would normally do with a dermatomal fashion, but the motor power, I would suggest doing a muscular tenderness type of neurological examination rather than a myotomal, i.e. check the power of these muscles and grade them according to the MRC guidelines. So i.e. 1 to 5. It is very important to do these steps because they will have implications if you do decide surgical management for these patients. Only a muscular tenderness units of grade 4 or more power would be available for transfer. And in real life, there is a large spectrum of patients where there may be very, very subtle weakness or no weakness elicitable in the clinic to massive weakness affecting almost all of these muscles. So you need to examine the power and grade them for tiband, tib post, peroneus longus, peroneus brevis, gastrosoleus complex, as well as EHL. Now, when you get a case of Pes Cavus, it is important to rule out other neurological conditions, especially if you've got a unilateral Pes Cavus. So you need to look out for cutaneous manifestations of spinal dystrophism, which suggests that there is some degree of either spina bifida or other neurological conditions affecting the spine. They commonly have weakness and wasting of the first web space. So you need to examine their hands as well. So if you have a system, I use the system for all my foot and ankle cases. This would be what you would find in the case of Pes Cavus, a high arch foot, a heel varus. They tend to recruit their long toe extensors when they walk to clear the ground. They've got a subtle foot drop. You need to individually grade the muscle power of all the foot and ankle foot tendons, as well as do a Coleman's block test, examine their hands, and look for the spinal manifestations of cutaneous manifestations of spinal dystrophism. Now, when you come to radiology, you should take weight-bearing x-rays of the foot. As John mentioned, you commonly find a calcaneus deformity in these cases, and there is a breakage of the Meary's line, which is the line along the long axis of the talus. Normally, it should pass through the center of the first metatarsal, but in cases of Pes Cavus, the first metatarsal is significantly plantar flex compared to the long axis of the talus. The other findings that you will commonly find in Cavus foot is that the medial cuneiform is significantly higher compared to the fifth metatarsal base. I've put an x-ray of a normal foot below that for you to appreciate the difference. Next, you'll find a flattened dome of the talus. It appears deceptively flat because of the rotational deformity. You'll also find that the lateral malleolus is significantly posterior compared to what it is on a normal view, which you can see below. Now, if you do have access to pedobarographs, they will show where they are predominantly weight bearing. They would be weight bearing predominantly on the tripod, i.e. the metatarsal heads, but you can commonly see a hot spot under the fifth metatarsal base because they tend to walk on the outer border of their foot. Now, if you do decide conservative management, which is commonly the main form of management for cavus feet, you need to give them support in the form of orthosis and insoles. Now, there are certain deformities that you'll find in a cavus foot. They commonly have a tight gastrocnemius complex with a silver skull test positive. So for that, you may have to give them a slight heel raise. If they've got a foot drop, you may need to include a foot drop splint into that orthosis. They have a hindfoot varus, for which you would use a UCBL or a cupped heel. That is much better than using a lateral post because that tends to make the heel slide down that slope rather than cup it. But in cases of more deformities, you may have to additionally have a lateral heel post in addition to your UCBL heel insert. You may have to give them a lateral shoe flare because they always have an inversion moment in their foot, which makes them give way because of that deformity. By giving their shoes a lateral heel flare, you are increases that fulcrum on the lateral side, and that gives them some stability. You'll give them an arch support. Because they have metatarsalgia, you would include a metatarsal dome to offload the metatarsal heads, and you would have a cutout under the first metatarsal head to let the first metatarsal drop and correct the deformity in those flexible cases. If it is a fixed deformity, you would give them accommodative footwear and not corrective footwear. Now, if you are planning surgery, the goal always for almost all the foot and ankle conditions is a stable, pain-free plantigrade foot. To achieve that, in cases of flexible deformities, we would do soft tissue procedures as well as osteotomies to correct the bony deformity. In cases of fixed deformities, we would do arthrodesis to correct those deformities. The correction of the bony deformities should be ideally done at the chora, which is the apex of the maximum deformity, and you should try to preserve as many joints movements as possible. Now, this is specifically like an a la carte method to cater to that particular patient. If you read textbooks, you will find hundreds of operations which are defined for cavus feet. It is very, very difficult to decide which one of them or which few of those operations do you need to do for this particular case. How do we decide that? We decide that in a simple menu. If you go to a restaurant, what you would have when you have a nice meal is a starter. In our case, the starter would be to put the heel under the leg. In these, there is a varus deformity of the heel, so we need to do some procedure to get the heel back under the leg. You would generally have a main course. In this case, we would have the main course as making the foot plantigrade so that it becomes shoeable. Most often, you would also have a dessert. And in this case, it would be balancing the forces around the foot to get the foot recurrence reduced. Now, how do we get the starter, i.e. getting the heel under the leg? We do that in cases of flexible deformities by doing a lateralizing calcaneal osteotomy. You could remove a lateral closing wedge plus or minus lateral translation to get the heel back under the leg. As you can see in the clinical photographs below, the varus heel has been corrected to a physiological valgus. The advice I would say in this case is to slightly overcorrect it because they have a common, if the balancing of the foot is not correct, then they have a high risk of causing a recurrence of the varus deformity of the heel. So try to give them a more 5 to 10 degrees of heel valgus when you do this calcaneal osteotomy. So in this case, we've got a significant heel varus preoperatively, and we would then correct it to get the heel back in neutral. These are the heel weight bearing axial views, which I commonly use in all cases. So that defines how my calcaneal osteotomy has brought the heel back under the leg. Now, getting the foot heel corrected, you could also cheat slightly and get the heel slightly dorsiflexed. This helps in two ways. It reduces the calcaneal pitch as well as it reduces the tension on the gastrosoleus complex. In cases of fixed deformity or with arthritis, generally if the patient is presenting to you beyond 45, 50 years of age, they may need arthrodesis, like a triple arthrodesis, to correct the deformities and get the heel back under the leg. Now, in order to get the plantigrade foot, you would correct the deformity where the apex of the deformity is. In this case, we would correct it with dorsiflexion osteotomy of the first ray to get that Meary's line corrected and restored back to neutral. You would then also need additional procedures to correct the toes. In cases they have got the apex of deformity is in the midfoot region, you may have to do closing wedge osteotomies of the midfoot, generally done at the level of the navicular-cuneiform joints and through the body of the cuboid. In certain cases, you may have to remove a trapezoid rather than a triangle of wedge to get the foot corrected. Now, balancing the forces, which is our desert. Now, to balance the forces, we've got weakness of the tibialis anterior. So we need to increase the dorsiflexion force of the foot. We've got to remove the deforming force, which is the plantar flexion force of the first ray, i.e. the peroneus longus. And we need to use the EHL to our benefit rather than it causing the clawing of the toe. We need to reduce the inversion force, that is, reduce the power of the tibialis posterior, and we need to increase the power of the eversion of the foot, i.e. the peroneus brevis. So how do we balancing it in the lateral view? So for increasing the power force of the tibialis anterior or the dorsiflexion of the foot, we can then position the EHL to the first metatarsal neck region, and also that helps in increasing reducing the first metatarsal deformity. We remove the peroneus longus as well. Now, in the inversion eversion moment, we need to augment the force of the peroneus brevis and reduce the force of the tibialis posterior. So we would do a peroneus longus to brevis transfer, which would reduce the forces which plantarflex the first ray. And we now have two muscles pulling and everting the foot, which increase the eversion force of the foot. We would use the tibialis posterior, pass it through the interosseous membrane in certain cases, bring it down to the dorsum of the foot, and implant it laterally in the lateral cuneiform or the cuboid, depending on the degree of deformity. In certain cases, you need additional procedures, i.e. if you're going for a meal and you're more hungry, you may add a side dish to it. Certainly, you may want to do a tendo-Achilles lengthening if you feel that the gastrosoleus complex is too tight. Very, very rarely, I've never done it in my own career, that you may need to release the plantar fascia. So, in a sense, you would try to correct the first ray deformities by using the EHL, implanting it in the first metatarsal neck, which dorsiflexes the first ray. You would do an interphalangeal joint fusion to correct the clawed toe deformity of the big toe. You would, if you need to correct the clawing of the lesser toes, you can borrow the EDL, and implant those into the metatarsal necks using suture anchors. You would also need to correct the claw deformity of the toes, for which you may need to do a PIP joint fusion or a flexor to extensor type of tendon transfer for the lesser toes, i.e. the Girdlestone type of procedure. Now, in a sense, we need to get the heel under the leg, you need to get the plantigrade foot, and we need to balance the forces. So if the deformity is flexible, we do a calcaneal osteotomy. If the deformity is fixed, we would do a triple arthrodesis. We would correct the deformity at the level of the apex of the deformity to get the foot plantigrade, and we would balance the forces, and these are the common tendon transfers that you may need to do. Now, the essence is to do minimum possible surgery to achieve the balance and the good results. You need to prevent or reduce the recurrence of the deformity, correct the deformity, and maintain as much movement as possible. And you generally use an a la carte menu where we get the heel under the leg, give them a plantigrade shoeable foot, and balance the forces.